Hi everyone, welcome to Surgery Dada, and this time again bang with a very interesting case. So this is the case of a 78-year-old male with a strangulated large loss of domain hernia, and this patient surprisingly is not fit for surgery. Why? Because this patient is having an ejection fraction of only 20%, because of which the family has been delaying the surgery for a very long time. So now we are going for a standard Lichtenstein approach, and 2 centimeter above the inguinal ligament we are making the incision. We have made the incision, extending it. Now in such cases laparoscopy is not possible because the bowel is already strangulated, so we need to go for a standard conventional approach. This case is really very interesting for all surgeons and young surgery residents who are in their early phase of learning. So nowadays we don't often do a lot of open surgeries. This is almost fourth or fifth open case of this year, because most of the cases that we do are TAPP for such cases. But yes, this is a really very interesting large loss of domain hernia. Now when we talk about loss of domain hernia, what is loss of domain? If the hernial content is out for a very long time and it's significant, so the original domain is lost and the bowel thinks that the next hernial cavity is its own designated anatomical site. So when such hernias are you can say reduced, there is always a risk of compartment syndrome. Now you can see there's a massive bulge at the level of superficial ring. I'm trying to reduce, but it is not. Now here using diathermy is really very dangerous. So trying to do a lot of finger dissection. Now you can see distended bowel at the level of superficial ring. Now we cannot proceed further until and unless we identify where is the external oblique aponeurosis. So we are trying to reduce the content, but it is not possible. Nothing is. We are almost clueless because we cannot trace external oblique right now. So superficial ring is visible, but external oblique cannot be traced. So gently, for the purpose of your reference, I'll tell you that I've increased the speed of this video to 1.3x. So we are doing meticulous dissection, a combination of energy source as well as finger dissection or blunt dissection, and very soon we'll be able to identify the superficial ring. So yes, at the location where I'm doing the dissection, we can find the superficial ring, and below that we have the external oblique aponeurosis. So we have been able to locate external oblique aponeurosis. So this is superficial ring, and now very careful will handle this. Now when you are handling the superficial inguinal ring, it is important to use 2 or 3 mosquito and an intermittent clamping and releasing. Why? Because the bowel might be lying just below and it can cause injury. So there is a small oozer which we are just using a cautery or electrosurgical source to coagulate it. So I was telling, whenever you lift the external oblique, first you hold, release. When you you can say release the hemostat. Yes, I'm holding it with a mosquito. Again I will use one more mosquito, lift it and release the previous one, and again I'll do it in a couple of times so that we get only the external oblique aponeurosis, and then we will take a scissor or a blade to cut through this. Now this is very important that we make a very small gentle cut, because right below maybe the bowel and its content. So a small nick, and then we will take dissecting scissors to open up the entire external oblique. Now external oblique means the anterior wall of the canal. So when we open up the anterior wall of the canal, then only we can enter. So just see, with the dissecting scissor I am creating the space, and gently I'm taking small bites at a time. Remember, small bites, small errors, and this is a universal principle in surgery. There is nothing known as fast surgeon. A surgeon can be right or wrong. This is what. So almost we have got hold, and now using Ellis forceps to hold the external oblique aponeurosis, and just see the anterior wall of the canal has been opened. Now like a conventional dissection, we will create some space, and the space is done inferiorly up to the level of inguinal ligament and superiorly up to the level of conjoint tendon, so that you can be easily able to lift up the cord structures along with the sac, and then you can separate it. But the problem here is there is so much of you can say content here. The bowel is not getting reduced, not able to lift it up, and the cremasteric adhesion. So basically this is a 10 to 20 years old hernia. You can see the conjoint tendon in the view down there, and these are all cremasteric adhesions which we will be taking off. But the problem is not this. The problem is we are not able to make out from where to lift the cord and the cord structures along with the hernial sac. So this is a classical combination of direct indirect hernia in this case. The posterior wall is also very weak, and we are trying to negotiate through the space that we are getting. In such cases, the bleedings might start from the cremasteric fibers, and we should be extra cautious when we are cutting them because they might bleed. But here, to my surprise, we are not able to get any space down there because this is a distended bowel here. Now, as we are stuck, we are not getting any clue where to go. We notice that there is you can say there is a constriction at the mid of the inguinal canal, and very soon you will be seeing that constriction. We are trying to separate it layer by layer, trying to have a, you can say, glimpse where we are, what are the structures down there, but we are not getting it. And after a lot of meticulous attempt, because here we cannot cut it directly because there might be direct perforation of the bowel, and that might create a lot of problem. So trying to tease off all the peritoneal attachments above, but again that is futile. We are not getting any clue. And the problem is that later you will see there is a stricture, and because of stricture the distal end, which is the hernial end going into the scrotum, it's totally distended. But after a lot of, you can say, efforts, we were able to negotiate through that stricture film, and we have divided the stricture half away on the side towards the scrotum. Just see, my finger was pointing towards the stricture side. We have to call the attendants of the patient to see what is going on, and so very soon we will open up. So you can see an hourglass effect here, and this hourglass effect is really very dangerous. Why? Because it is the cause of obstruction here. So hernia is there, hernia along with the adhesions. Yes, this is the place where we have the constriction, and this needs to be released. Once this constriction is released, a lot of stretch and strain over the bowel will be reduced. So these are the cremasteric fibers which are causing the obstruction midway, and we are very gentle because doing an inadvertent injury might cause a catastrophe. We have even counseled their attendants that we might be going for a colostomy or ileostomy based upon what segment of bowel is incarcerated or necrosed, because currently we are not knowing where we are standing. So you can see we are opening up the stricture again, and there are so many layers of cremasteric fibers which have created a stricture. It's dense stricture. So let us see how well we can negotiate through this. Almost we are done. We are trying to cut layer by layer. So every layer is important, every layer. Now these surgeries are you can say are an exception. You don't get to see all these cases every day, but patience is really very important. If a surgeon who is operating is not holding the patience, he will definitely do an injury. So you can see I'm very careful while using electrosurgical unit, because thermal injuries in these cases might go unnoticed and might be noticed later. Now trying to again negotiate through the stricture segment. So this is basically the hernial sac which we are opening, because on the external surface of the hernial sac there is a stricture developed, and now you can appreciate the bowel. So we have almost opened up, and there is lot of, you can say, hemorrhagic fluid which is coming out. Might be the collection inside or might be any active bleeding, we'll see later. Now on the distal side also that stricture has been opened up, and you can see the bowel popping up out. So now we'll examine the bowel, whether there is any, you can say, gangrene or no. But yes, the dusky dark fluid is really very surprising. So it might be leading to some internal, you can say, internal necrosis. Even later, when patient underwent, you can say, a Doppler scan after recovery, because this patient has already recovered, so there was loss of vascularity on this side of testicle. It may be because of the increased intrascrotal pressure. So now you can see the omentum popping out, the dusky yellow omentum along with the bowel popping out. So almost we are cutting up. Now we have got that this is the peritoneum, this is the cavity, this is the sac, each and everything is here. We are taking a warm mop so that gently we can allow vasodilatation and good vascularity of the bowel. We are trying to take out everything and just see the amount of content coming out from the scrotum. And we were lucky that the necrosis didn't happen, because in such scenarios necrosis is inevitable if the time is wasted. Already this patient went from pillar to pillar, from one hospital to another, searching for an opinion, but most of them denied, because this is a very high risk case, and in such cases it's very difficult for the patient to survive, and this earns a bad name for the hospital, because eventually doctor is blamed for not being able to survive the patient. So you can see we have taken out the omentum, and this is the omentum. We have the bowel. Now the next task is, you can see I've used a warm mop so that we increase the vascularity. Now trying to negotiate through the, you can say, stricture planes, removing the cremasteric adhesions which are there, and trying to go to the level of deep ring. Why it is important to go to the level of deep ring? So that we can reduce the content. So already we are trying to reduce, but it's a case of loss of domain, so it becomes very difficult. So we have to do all the dissection right up to the level of deep ring, removing all the cremasteric adhesions, and very gently we are pushing the bowel. So some of my movements might be appearing crude and swift. It is because the video is in almost 1.3 to 1.4x mode. So the bowel is going inside, but we are ensuring that we don't damage. So since the omentum is healthy, we decided not to cut and remove the omentum, rather reduce it as much as possible. So in such cases, if the omentum is necrosed, or if half of the omentum is you can say getting pushed and half is not, you can also cut and remove it, but I would advise not to do, because omentum is having high vascularity, and many a times the vessels might go in vasospasm at the time of division, and it may bleed a lot. I've seen a lot of patients having the same problem. So you can see slowly with guided movements, everything has gone inside. And this gives a lot of relief that we had reduced everything, and almost everything has gone inside. Nothing is there in the scrotum. So after a hurdle, almost this surgery took 2.5 hours. Whatever you are seeing is a cut short snippets of the steps. So I've recorded it for academic purpose as well as for the reference. So now the next is to identify the cord structures as well as delineate and separate them. So there is, in such cases, the cremasteric adhesions are the main problem, because there are so much of cremasteric fibers which are cording adhesions. Now you can see I'm trying to lift up the cord and the cord structures. So just with a standard maneuver using 2 fingers, a thumb and an index, and trying to make up a window, I will simply, yes, you can see I've got the latch of the mop and lifted it. Now the next task will start. The task is to separate the cord structures away from the redundant, you can say, tissues, and we've almost got the cord and the, you can say, the spermatic complex. So let us understand this. Now whenever you are doing this, again cremasteric fibers can cause a lot of bleed, and we are just very careful. I'm focusing just on the vas. So these are all cremastic fibers which we shall remove it. Remember, when you are handling such cremastic fibers, always ensure that the bleeding is stopped, because they cause a lot of bleeding, and it creates an impact when you're putting up a mesh, because there is a lot of oozing in such cases. So again, repeating the same procedures, separating the cremastic fibers and taking them down. So these are a series of combination of blunt dissection along with the using electrosurgical unit. We are almost half a way of the surgery. Now, in these surgeries, always remember, if there is any bowel injury or if there is any injury that you cannot repair, always ask for a help. There is nothing known as ego. If you are egoistic, you will not be able to operate on such patients. Because if you're not confident of surgery, don't give someone else a chance who can operate. There is nothing known as ego. So you can see this is the peritoneal cavity or the peritoneal wall which has been left behind on the scrotums, on the scrotal side, because we had to divide through the hernial sac, peritoneal sac, and reduce the content. So this is the redundant side of the peritoneal cavity, which is almost there at the level of, you can say, the scrotum, because the abdominal part has already been reduced. So trying to find the vas, each and everything, same procedure being repeated again and again. Now everything has been delineated. So all the things have been done. Now we shall be going for a complex repair, where we will be going for a triple repair along with the mesh, Lichtenstein mesh repair. So when we talk about the Lichtenstein repair, it's a simple mesh placed on the posterior wall. But when we talk about the triple repair, we are going to suture conjoint tendon, which contains internal oblique as well as the fibers of transversus abdominis, and we will be taking interrupted bites with the inguinal ligament. So that is the reason, since we are taking three structures together, it is known as a triple repair. The standard Bassinis or a Scholdites are all standard triple repair. It depends on what technique. So here we will be using an interrupted. But before that, let us see, we remove all the redundant things and divide them. So this is a part of the redundant sac that we have. We shall also be excising this also, because it's useless. We have already excised the part which was located in the proximal end towards the abdomen. So this is the distal end of the sac. We will be you can see the sac and the cavity. So we will be removing it. It's of no use. Already everything has been removed. I told you this is a combination of direct and indirect hernia. So the redundant part will be removed and the remaining will be ligated and pushed back inside. So you have seen already the content has gone back through the deep ring. Now this is the external, you can say, this is the direct hernial sac which we are seeing right now. So after dividing, we'll reduce it also, and we'll suture and reduce basically. And next is you can see everything, the sac, this is the part of the sac which was towards the scrotum. Almost got it. Now why it is important to remove them? If you don't remove a part of it, nothing will go. But there's a chance that since this patient is an elderly, there could be fat necrosis of this or necrosis of this part, resulting in infection and maybe a secondary infection to the mesh also. So that is why, as much as you can remove, you should be removing, because large fat content or necrotized muscles are a source of, you can say, infection. And this creates a second problem, because you have taken so much of pain, you have operated on these patients, the patient survived, and then just because of the infection, so we are spending some extra time removing all these things. Remember, when we are doing this, we are extra careful that we don't cut and divide the cord structures. Anyways, we have already secured them. So you can see down there we have the spermatic cord in the view, in between the two fringes, you can see. Now, meanwhile, the second team is preparing the mesh for the placement. Almost we are at the end of the surgery. These cremasters or cremastic fibers, they are really problematic. They create a lot of chaos. and they consume a lot of time also. But anyways, in hernia we have to show a lot of patience. So done, almost everything has been done, all the redundant part has been removed. Still we are getting something, so still skeletonizing the cord structures. So this is part of open hernia repair. Now imagine if you were doing a TAPP, this part is non accessible, and even if you pull the structures from inside, they will not get reduced, leaving you in a chaotic position where the structures have been reduced, but a lot of fat or momentum has to be divided in order to proceed. I have experienced such cases since I have operated. My center is a high volume surgical center where we are regularly operating all these cases. So when you are operating on high volume cases, you always get to face a lot of new complications. A surgeon who doesn't face this complication means he is not a surgeon or he has not gained sufficient experience. So this is all redundant tissue, and we shall get it removed, and rest everything is ready now. So with the Proline 2.0, we are going to do a triple repair. Shortly you will see how a triple repair is done. So everything is done, everything is reduced. A hernia which was virtually you can say looking like it would never get reduced is already done. Everything, the cord structures are preserved, everything is there. Let us see how the deep ring is approached and how we strengthen the posterior wall. The ideology here is to strengthen the posterior wall and get the structures reconfigured so that the hernia is prevented. Again, some more of cremastic fibers. So I am very particular about this because they are the source of secondary infection, and that is how lot of you can say my residents tell that sir, we operate a lot of hernia cases, but the mesh infections are inevitable. The mesh infection will happen when you leave a lot of dead space, lot of dead tissue, lot of necrotized tissue in the hernial bed. So inguinal canal has to contain only the spermatic cord and the structures which are meant for that. If you have other structures, or you can say necrotizing structures, infection has to be there. So let us just see. I am taking bites. So the bite over the conjoint tendon, you can see the shiny white glistening aponeurosis, that's a conjoint tendon, and the second bite has to be taken over the bottom glistening structure. What is that bottom glistening structure? This is inguinal ligament. So with the help of interrupted sutures, now you don't have to be very tight in approximating, but still yes, it should be good approximation, not very tight, because if you do it very tight it might cut through. So 3 or 4 bites are sufficient in this zone, and this will be really helpful for the patient. So almost done. This bite is there. Since we are using Proline, we give 4-5 throws. Again a second bite being taken. Now when you are taking these bites, always remember that the needle has to go tangential to the surface so that you don't go very deep inside, because there is a risk of vascular injury, and you are approaching the posterior space where the inferior epigastric vessels, the femoral, each and everything is there. So you don't have to take very deep bites. The bite should be such that you take the conjoint tendon as well as the inguinal ligament and approximate it. Remember to take an inguinal ligament, not to take the external oblique, because if you take external oblique, in that case it really becomes difficult for you to close the canal, because where will you put the mesh, and then where will you fix the inferior edge of the mesh. So almost everything has been done. We have taken almost 4 bites, and this is what is a classical Little's repair. Basically in hernia there are a lot of surgeons who have given their own you can say approach. So I have my own way of operating such hernias, and you can see I always do a triple repair along with mesh. So it's a combination of triple as well as mesh. I call it my standard SD's dissection and technique. Let us move forward and let us see how we place a mesh. Now almost the surgery is done. We will now be placing a Proline mesh. So you can see the Proline mesh is there. We have already cut it. If you see, we have to divide the mesh into 2 leaves so that one end stays down, one end stays up, and there's an olive like cut through which the spermatic cord will come. So basically this is going to be placed on the posterior wall. So cord has to come from the posterior wall and go into the deep ring. This is very important. So it is coming from the scrotum, going through and entering the deep ring. So the first bite is taken with the pubic tubercle. In laparoscopic repairs like we do TAPP, we take the first bite with the conjoint, we take it with the Cooper's ligament. So here it's the pubic tubercle. And then there are series of fixations that we do. So you can use 2 to 3 interrupted sutures with the internal with the inguinal ligament, and 1 or 2 with the conjoint tendon, and this is more than sufficient. Some surgeons use more also. Some surgeons might use continuous, but there is no added advantage. The mesh, the ideology is mesh should be fixed in such a way that it snugly fits without getting curled up, or you can say without getting doubled. So we are creating the space, and we have almost put it into the inguinal canal, and just see, yeah, the mesh has been perfectly placed into the canal along the posterior surface, on the posterior surface, and we'll be putting the bites. So this is a really very simple surgery, but in such cases it becomes really very dangerous. But patience, like I always say, patience is the key to success in them. During this surgery, let me tell you, I also thought there was a time when I was not getting any clue about the bowel, and when you are dissecting through a space where just below is the bowel, we get fear or we get chill down the spine that, oh my God, let us not injure the bowel. Because in the bottom of you, inside your heart, you know that you could have avoided that injury, which you did. So you can see the mesh is fixed, everything is ready. Almost the lower end is fixed, 1 or 2 bites on the upper end also, and we'll also fix the 2 edges of the cut ends so that we create that neo deep ring. So a new deep ring is created, or a neo deep ring is created with the help of this concept, and the entire posterior wall is going to get strengthened. By the time I'm recording this video, this patient is almost a month and above. Patient is absolutely fine, and this is the charisma of surgery, that you can give immediate relief to a patient who was almost on the brink of getting collapsed. So we doctors are not magicians. We put our all efforts. Many a times it happens that despite these efforts, we're not able to save patients. You can see we are fixing both the cut ends, and almost it's done. Everything is okay. So we're using a 2-0 proline in this case. 1 or 2 bites is sufficient, and I'm placing 1 or 2 bites on the upper surface of the mesh along the conjoint tendon so that it stays there. And once we are done with this, you can see there is no extra content, there is no necrotic content in the inguinal canal. Inguinal canal is absolutely clean. This is very important to prevent mesh infection. And now we'll be going for the closure of the anterior wall, and that is external oblique aponeurosis. So we are going to hold the you can say the external oblique, the cut ends of external oblique, starting from the corner. Now here we are going to take proline, no, we are going to take Vicryl. So we take Vicryl number 1, and we are going to take the corner, and in a continuous fashion we are going to approximate, close it. This is a very, you can say, interesting surgery. Sorry for the delay, I brought it late because got occupied too much with high volume cases and difficult, dangerous patients. I had to do a voiceover because there is a lot of chaos in the OT. Lot of you can say me shouting at the staff, so I had to do a voiceover in this case. I thought of uploading a raw video, but only surgeons could have appreciated that. Otherwise everyone would have said, oh my God, you're so, you can say, loud in OT. Because many a times when you're operating such cases, the adrenaline is on the very higher side. So I keep on bringing such cases for the residents, for the surgeons, for the public, for their awareness to understand what is surgery, how it is. So surgery is about knowing what to cut, what not to cut, and when not to cut.